Hello, BDO family, and thank you so much for tuning in for yet another show on BlackDoctor.org. My name is Jade Curtis. I am the executive editor of BlackDoctor.org, also known as BDO, and we are going to have an important discussion today about infertility. So here's the thing. Black and Latina women are more likely to be diagnosed with infertility, but often face bigger hurdles when it comes to getting care. We're breaking it all down today with Dr. Deborah Ikenna Abel, a reproductive endocrinologist and infertility specialist at the Aspire Fertility Austin Clinic. And so we'll be talking about common conditions like PCOS, endometriosis, and fibroids, and why they tend to impact Black and Hispanic women more. Plus, we're going to dig into why getting help isn't always easy and what we can do about it. So if you've ever had any questions about infertility, or if you're here to support a friend or a loved one, this is the place to be. We're going to call her Dr. Debo today. Asia, you can go ahead and bring her on in, but Dr. Debo is going to share some really, really incredible information with us. So thank you so much for joining us today.
Yeah, thank you for having me. I'm so happy to be here.
Absolutely. And we're happy to have you. So, if you could go ahead by starting us off with an overview of what infertility is and how common it actually is in the US.
Yeah, so infertility refers to the inability to conceive, and there are different parameters based on your age. For example, as to how long of trying to conceive categorizes you as infertility. So if you are under the age of 35 and you've been trying to conceive for 12 months, then that is termed infertility. And if you're 35 to 40, after 6 months, that is deemed infertility. And after age 40, the recommendation is to really start the evaluation process as soon as possible. About 1 in 6 people will struggle with infertility at some point in their lifetimes, which is a lot more common than a lot of people assume it is when they are not familiar with the disease etiology.
Absolutely. And so, is there a difference between Black, white, Hispanic? How often does infertility, or how does infertility affect different racial or ethnic groups, especially Black or
Yeah,
Latino women?
Yeah, for sure. So the data show that Black women are 2 times more likely to experience infertility when compared to women who are Caucasian, and then women who are of Hispanic origin are about 1.5 to 1.8 times more likely to experience infertility. So there's definitely an increased incidence of infertility in Black and Hispanic women. However, there is less access to care in those groups as well.
Absolutely. And so, can you tell us a little bit more about why that is? What are some of the causes of infertility and why, they are disproportionately impacting Black women specifically?
Yeah, so in terms of why we see this disproportionate effect in Black women, I think part of it has to do with some conditions that lead to infertility are more common in Black women. Most notably being uterine fibroids. So women who are Black or of African descent are more likely to have fibroids compared to other races. We think part of this may be due to the fact that we're also more likely to be vitamin D deficient, and there's some data showing that there might be a link between being vitamin D deficient as well as having uterine fibroids. That being said, we also believe that there might be some underlying genetic predisposition to uterine fibroids among women who are Black or of African descent. So that's one of the key reasons we see infertility more common in those groups. Another reason is, culturally, I feel like a lot of women who are Black, whether it be African American or diaspora, tend to come from a culture where they're told that they're fertile and cannot have infertility, or that being infertile is a mark on their character in some way. And so we tend to present later to care. And unfortunately for infertility, age is a very strong predictor of both the chances of success from treatment and the options that are available for you when you present to care. And so that is part of the reason that we do see this increased incidence of infertility in women who are minorities. And I would say a third reason is that there's some other healthcare comorbidities, such as high blood pressure, obesity, that could impact your fertility and your reproductive health, that are also more common in Black women a lot of the times due to socioeconomic factors as well.
Gotcha. Very, very interesting. So that leads me to wonder, and I'm gonna kind of throw a curveball at you with this one. I know we didn't prepare this question, but are there things that you can do to kind of see if you are infertile? Is there testing, or say if you're planning, like say you're in your teens or your 20s, and you're not really thinking about having a child yet, But maybe later on, is there a way that you can see if you're, infertile, and maybe that'll change the way that you plan your entire life out? Are there tests? Are there screenings?
Yeah. So I think that's an excellent question, actually, because we live in a world where we do have options that can help us plan our fertile future or our reproductive future. I would say that once you're kind of thinking that you may want to have kids in the future, it doesn't hurt to check your AMH level. Now, AMH is a blood test that tells you about your number of eggs. And it's an interesting test because it doesn't predict whether or not you'll be fertile, which is the question most of my patients want to answer, like, am I going to be infertile? Because there's so many different things that can cause infertility. But it does predict if you need fertility treatment, how likely are those treatments to be successful, right? So the number of eggs you have and your age at the time of fertility treatment are very predictive. So I would say it doesn't hurt with your annual exam to check an AMH. And if you're kind of getting close to your mid 30s, 33 and older, and you're not ready to have kids yet, it's not a bad idea to consider freezing your eggs if that's an option that is available to you, whether through your employer offering insurance coverage or financially available to you, because that gives you kind of like a fallback. It's not a guarantee, but we know that 33-year-old eggs will have a much better chance of resulting in a baby or babies than 38 or 39-year-old eggs, for example.
Gotcha. And I want to take it back to something that you just mentioned as well, and how, if you find out that you are infertile or whatever the case, it can kind of be a mark on your character. And I guess that can lead women to feel uncomfortable talking about infertility or even asking their doctor. So I guess, how can we start to open up those conversations and just be more comfortable talking about it, talking to family, friends, doctors, parents? How can we kind of change that narrative?
Yeah, I think a very important part of that is honestly sharing our stories. I think that, we underestimate the power of our stories a lot of the time. And, I didn't struggle with infertility specifically, but I did struggle with recurrent pregnancy loss. And, when I mentioned that to my patients, it makes them feel like, oh, okay, like, well, if you're a fertility doctor and this is your specialty and you struggle with this, then it's not because I am defective in some way. Like, sometimes these things just happen and it's not a result of some bad decision that you made, and so because it's not a result of something that you did wrong, you're not really going to fix it by doing things right necessarily. Of course, there are things we can do to optimize fertility and pregnancy, but it's important to understand that a lot of the time, just like it is with other medical conditions, it's not because you're defective or you've done something wrong. It's just that sometimes, things happen to us as we progress through our lives. And like any other medical condition, we should feel comfortable asking for help, seeking out care, and advocating for ourselves. But I think the first step is really to share our stories more often.
For sure. I love that. And if anyone is seeking more stories or information about this, blackdoctor.org, we share a lot of stories like this. And even if you have a story to share, we'd love to hear that from you all as well. So while we're talking about care, what are some of those bigger barriers that, Black women or even Black men tend to face when seeking infertility care?
Yeah, so one of this data that I found pretty surprising is that Black women are less likely to be referred to a fertility specialist than women of other races. It's unclear why this is the case, but I think that it is important, if you know that you've been struggling to conceive for a while, to, you may be told, what, it's okay, just keep trying. But if you've been trying for, a year and you're under 35, or for 6 months and you're 35 and older, to say, what, I know I can keep trying, but can you just put in a referral to a fertility doctor just so that I can talk to a specialist and see what they have to say about it. And then if you have, and some insurances don't actually even require a referral. So you can just call up the fertility clinic and say, hey, I would like to book an appointment with my fertility doctor. And a lot of the time, if your insurance requires a referral, then they'll let you know and then kind of help facilitate that process as well. So I think with regards to that, a big part of it is really just advocating for yourself so that, you're not kind of being, unintentionally made to delay seeking care. I think another big barrier to fertility is cost. Unfortunately, in the US, a lot of the time, fertility care is not treated like the rest of healthcare, and so it's not covered by insurance. And so there is this perception that infertility treatments are more expensive than other things in healthcare. And the truth is, they're not more expensive. they're just not covered. And so the patient sees the entire cost of the treatment. And if someone doesn't have the financial means to go through fertility treatment, then that's going to hinder them getting care. And an interesting thing to note is sometimes people don't know that there are actually financing opportunities specifically for people who are going through fertility treatment. And so just because you don't have cash in hand to go through treatment doesn't mean you should throw in the towel. Like two organizations I can think of just right off the top of my head are Patient Fi and Future Families, which are organizations that really specifically help to finance the cost of fertility treatments. And so I think, sometimes that just not being educated about your options when you don't have that cash in hand and you don't have insurance coverage can deter people from seeking out care due to cost being a hindrance. And then a third thing I would mention is, unfortunately, we have studies that show that even when they have, fertility coverage, they've made it to the fertility doctor's office, Black women are less likely to continue care. And we think part of this has to do with, just feeling at home in your chosen healthcare provider's office. And I think sometimes, if you feel like you're interacting with a provider who doesn't either see you or get you or, doesn't vibe with you in a way that is true to who you are, I think instead of giving up, which is understandable, this process is very stressful, to consider maybe seeking out a second opinion or a third opinion, or asking, if you know of a friend who's seen a fertility doctor, like who did you see, so that you're able to find someone who better speaks to you and your journey, so that you don't give up on your journey because of something you cannot control, which is, the dynamic you have with your healthcare provider. And so why it's annoying to have the onus be on you to find someone who you work well with, but at the same time, if you know that this is your dream and you want to grow your family, I think it's definitely worth taking that next step.
Absolutely. And I love that you mentioned going to seek out a second or third or even a fourth opinion, because I think when we get really close to our gynecologist or, the OBGYN that we're working with, we tend to feel like we're kind of stepping out, but it's okay to go get a second or third. It's not stepping out. So I really appreciate you mentioning that. And there was something else that you mentioned that was going to lead me to my next question. Now I cannot think of it, but I hope that they remember, but I cannot think of it. But either way, you mentioned the referrals. And so you mentioned how a lot of Black women tend not to be referred. And I know that there tends to be a lot of medical bias as it relates to Black patients going into care. So do you think, or I guess I'm asking, what role does medical bias play in infertility care, or is there even medical bias? And then how does it affect diagnosis and treatment options for Black patients?
Yeah, so I think, unfortunately, I think medical bias was always a factor. We all have bias, and so I think to say that there is no role for medical bias would be very ingenious of me. That being said, I do think that for some people, not all, there is that perception, that you're Black, you're probably going to be fine, you're probably fertile, or you're Hispanic, you're probably going to be fine, you're probably fertile. Like that kind of mindset of like, infertility is more so a disease of like someone who is not Black or who is not Hispanic. So I think that's part of it. I think the other bias is the assumption of they probably can't afford IVF, so why even send them to the fertility doctor, which is another bias, or they might be offered less effective treatment options because of the I had a patient who saw me very recently who is 39, has a low egg count, and like IVF is very clearly her best option to conceive, but she had been seeing someone else and they had offered her an option for people who are young and have very good egg counts. And I was like, so I asked her, like, why do you think they gave you? So she had done her own research, and she's like, well, the research tells me that this is not the best option for me. And so I asked her, like, why do you think that this was what was offered to you? And I think it honestly came down to, they thought, most likely based on her appearance and their perception of her appearance, she would not be able to afford IVF. And so I think sometimes that unfortunately does play a role. And I think it's important for us to realize that we all have bias, right? And to constantly make sure that we are treating every single patient that we see in the same way, that we're offering the same options to every single patient that we see, that we're not making assumptions about people's desire to move forward or capabilities to move forward based on, our own like preconceived notions, which a lot of the time, ends up being incorrect.
Absolutely. And so if maybe if these things aren't brought up, can we just talk about what some of those options are? So maybe if a patient does go in the doctor's office and they aren't offered, they know what to ask for. Like, hey, you didn't mention this, this, or this. Is this an option? So what are some of those options?
So, it really depends on the diagnosis, right? Because, with infertility, there are a myriad of diagnoses, and there are some options that are really effective for one thing, but are not really a great option for something else. And so, I'm going to start with something like unexplained infertility, because that is one of, I think, the more frustrating diagnoses. It basically means that they've had a workup. They've looked at the sperm, looked at the eggs, looked at the tubes, uterus, everything looks normal, but we don't have a clear reason for why they're not getting pregnant. Now, in the setting of unexplained infertility, meaning that the woman has regular periods and everything is normal, we have very good data that taking medications to make you release more than one egg without combining that with an intrauterine insemination, which is when we put sperm directly into the uterus. So just taking the medicine on its own does not increase your chance of getting pregnant. Now, I see a lot of patients who have done that for 6 months, for a year. Like, they have unexplained fertility and they've been taking Femara every month or Clomid every month, and they're not pregnant. They're like, why isn't it working? I'm like, because unfortunately the data says that this is probably not going to work. You can definitely get pregnant on that, but that probably is a pregnancy that you would have had on your own anyways without the medication. And so when you have someone presenting with truly unexplained infertility, their first line should be a combination of IUI, intrauterine insemination, and the medications together to truly cause a bump in their chances of conceiving. Now, if someone shows up with something like PCOS, where they're not having periods, that's the patient that the medication alone is very effective for, because you're treating what's causing, they're not ovulating. And so you give them the medicine, now you're making them ovulate, now you're increasing their chances of getting pregnant. And so it really kind of comes down to what the cause of infertility is. And so sometimes, they might be seeing a provider who doesn't have the capability to do IUI. And some providers will explain that. They'll say, you know what, I don't do IUI in my clinic. I can offer you this, but it's probably not the best option. And they say, yeah, I'll just do it anyways. And that's fine, because both parties are, there's transparency, there's an understanding of the limitations of that option. But in other cases, they may not understand that this actually may not be improving their chances of conception. And in that scenario, I feel like they're kind of losing time, which in the world of fertility, time equals age equals chances of success.
Gotcha. Thank you for that. Okay, so my next question is for, there's always a portion of our community who tends to lean more toward holistic, natural remedies, things like that. And so maybe, are there any remedies or any lifestyle changes that people who are dealing with infertility can possibly do to potentially improve their circumstances or change their outcome? Is that a thing?
Yeah, for sure. I think that, when you think about it, at the end of the day, the egg is a cell and the sperm is a cell. And these are cells in our bodies. And so the health of our bodies affects the quality of the eggs and the sperm that we're producing. And so I always like to start off with the things that have the biggest impact, which are nicotine, vaping, anything along those lines. That we know that if you were to pick one thing to discontinue, it would be nicotine, because that has a very strong impact on both egg quality and sperm quality. So much so that women who smoke or vape go through menopause 2 to 5 years earlier than their counterparts, because their eggs are depleted at a much faster rate. So that would be like my first thing to recommend. Then, of course, the next thing I would talk about is marijuana. The data on CBD is not as strong, but we know the marijuana isn't great for eggs and sperm, especially for sperm. So I would definitely recommend cutting that out as well. Now, as far as supplements, I think vitamin D is a good place to start. Being on a good prenatal vitamin with folic acid is also very crucial. I usually recommend about 800 micrograms at least of folic acid. So I think those are like the good building blocks of like where you want to start. Now, other things that can be important when it comes to diet and nutrition, the diet that has been linked with improved fertility outcomes is the Mediterranean diet. And I tell people it's not because olives are good for your eggs. It's not about the specifics of the diet. It's because this is a plant-based diet. It's a whole foods diet. So you're not eating as many processed foods. You're eating all your colors. So lots of, natural antioxidants, so vitamin C, etc. And you're eating a lot of whole grains. And so you're not eating processed foods that will cause like a spike in your blood sugar levels or a rise in your insulin levels. And so you're really kind of doing all of these things that are improving and maintaining your health overall. So I would say from a nutrition standpoint, you want to focus on the whole plant-based diet. And as far as like sources of protein that are animal-based, probably fish and chicken, I would say preferably to beef. And I think if you're doing all of those things, you're headed in the right direction. Now, there's some supplements that can also help to improve egg quality, like coenzyme Q10. But really, I'd say start with the diet and cut out the toxins, and then go from there. Because if you're not eating right and you're smoking and taking coenzyme Q10, like the nicotine is going to be canceling out the CoQ10 every single time.
Okay. Mm-hmm. Okay, nice. So we've talked a lot about women's role in infertility, but I know that men can also be infertile too, and can they also contribute to women's infertility? Like, are they stressing us out that much? No, I'm just kidding. But can men also contribute to women's infertility as well, or can men just be infertile? Sorry.
Yeah, men can definitely be infertile. Now, unfortunately, because the woman carries the pregnancy, it is viewed as a feminine issue. But we know that about 40 to 50% of the time, it is a male factor infertility. There's something going on with the sperm. And about 30% of the time, so 1 in 3 couples with infertility has both a male and female issue going on. So I have some patients who will come to me and say, hey, I know I have irregular periods, so I know it's me. I'm like, no. You have one possible cause, but we still need to look at the sperm, because reason why he can't also have something going on. And so every couple I see that is a heterosexual couple, the male partner will also need to get a semen analysis, because we need to make sure that there is sperm present, that the sperm looks normal, is moving normally, there's enough sperm present, because we know that male factor of infertility is a true thing.
Wonderful. Yeah, I'm glad that we got to address that, because as you mentioned, infertility tends to be looked at as a female problem. And when it comes to infertility, both men and women should be getting tested, should be being checked, and should be partners in exploring that journey and figuring out what their best solution is. So thank you for clarifying that for us.
Yes, of course.
Yeah, and so I'm really happy that I'm always happy to sit here with a Black doctor and talk about Black health. But I do know that in this space, there is a lack of Black fertility specialists and reproductive endocrinologists, excuse me. So how can that impact patient outcomes and even trust within the system?
Yeah, I think, whenever you see a physician who you can identify with in some way, it definitely impacts your experience of getting care. And I do think, at least I try when I see all of my patients, to try to make sure that they understand that I empathize with them, and I truly want what is best for them. I want them to think of me as like a team member, where we're working towards a common goal together. Like, my first question is always like, what are your goals for this visit, right? So that we are working towards a common goal. And I think that, a lot of the time, unintentionally, there can be, like we talked about earlier, bias introduced into, an encounter, because there isn't that kind of shared background or an understanding or respect of a different background. Because even if you don't share someone's background, you're still able to respect it, understand it, and also ask questions about it, so that you better understand, what exactly you're trying to navigate. And so, while I do think that we are getting better. For the last few years, ABOG, which is the American Board of OBGYN, has included, modules on, implicit bias in our training, so that we can better care for patients of all backgrounds, because the data is very clear that it can negatively impact care. So I do think that we are getting better, but there is still, a long way to go. And I think a big part of that is also just letting people know, like, this specialty exists. I can't tell you how many people I've met who are like, how did you become a fertility doctor? Like, what specialty in medicine takes you here? So sometimes it's just the basics of like, this is how you become a fertility doctor. And then there's other things like, if you're pre-med, this is how you plan your pre-med classes. This is how you, study for the MCAT. Like, a lot of things that seem really dry and boring, but end up really affecting your long-term goals. And I feel like, having lived this journey, there's a lot that I learned from, having friends along the way who had either done it before me, or advisors who had advised other students and were able to tell me like, hey, maybe you want to like do X, Y, Z in this way, or, and so I think it's those little things. And I think mentoring and things like that can be helpful in us kind of paying that forward.
Absolutely. Well, Dr. Debo, I want to thank you so much for your time. And before we go, I do want to ask you if you have any tips or strategies or maybe a key message that you want to share with our audience who may be dealing with infertility, anything that you want to share, I would love for you to take a moment to share that with us.
Yeah, I would say that if you're struggling with infertility, to know that you're not alone and that there are options available for you to achieve the family of your dreams and to not give up. I think that sense of being alone can really magnify everything else that you're experiencing. And so, as much as you can to find your tribe, there are so many other people who are on this journey with you. So you're definitely not alone.
Absolutely. Well, Dr. Debo, thank you so much for your time. This has
Thank
been
you for having me.
absolutely, it's been so informative. And BDO family, if you have any questions, if you see this at a later time, please feel free to leave any comments or questions in the comment section. And hopefully, if Dr. Debo lets us, we'll relay them onto her.
Of course.
And have them, and have us respond in maybe an article or a follow-up Facebook Live. So thank you once again for joining us, and we will see you all soon.
Thank you.